Good afternoon. It's a pleasure for me to start with these seminars and these lectures about the multi-technique is my technique in orthodontic. And I would like to talk about the efficiency, the concept of the efficiency, to diminishing the time of the treatment, to get the best results for our patient after the crisis of the coronavirus. And I think it's very important because we need simple techniques, cheap appliances, diminishing the price of our treatment, because this is the future of our profession at most during 2 or 3 years. I'm going to start this group of seminars, and I would like to the presentation of myself, talking about my training, my work, a little bit about my life, and about the most important is about my orthodontic philosophy. I live in Santiago de Compostela, a very small city, in the north of Spain, close to the border of Portugal, surrounding my city. Is a lot of monuments. The landscape is beautiful, and we have a lot of kilometers from coast. Galicia is very famous for the Cathedral of Santiago de Compostela. The cathedral is a Romanesque style, present one of the best portico of the Gloria, the best sculpture as a whole, and is very famous also for the Botafumeiro, and this is the like incendiary. It's a small city, very nice. Since Santiago is the finish of the Camino. The Camino is a long way from the north of Spain, close to the border of Portugal. Even people come to Santiago walking from France and from Italy, about 600 miles. And this year is a little bit different for the coronavirus crisis. I work in the University of Santiago de Compostela. I am the chairman of the orthodontic department. And my training, I studied first 6 years of medicine, specializing TMG, anthropologists, after study dentistry in the faculty in the University of Oviedo in the north of Spain. My main topic during my dentistry was occlusion, the use of the different types of articulators. My doctoral thesis was about the trigeminal nerve, the role of the trigeminal nerve in the stomachnotic system. And after that, we studied with Professor Canut at University of Valencia 2 years and a half in the master's degree with a full-time specialty. And we used the tweeted technique, we used the rickets technique, the use of the functional appliances, the use of the functional appliance, and I also professor from the university, and I funded with another professor, Abel, the Center of the Craniofacial Deformities in the University of Santiago. I was president of the European Orthodontic Society and organized the Congress in 2012 in Santiago de Compostela, a huge congress about 2,000 doctors and orthodontists around the world. And with the Rocky Mountain Company from Denver, we use the development, the straight wire, low friction with the synergy bracket and with the new high technologies alloys. Okay, this is the synergy bracket. We use a lot I like very much the synergy and the new alloys. And today we are using a new technique in the straight wire low friction. Is the combination between the synergy bracket and the gum metal. Thanks to this, it's possible today in 75-80% of the cases to use only one wire for all the treatment. Start with a round wire, and the next wire and the last wire is a 90 by 25 gum metal, and with two wires and the same alloy during the treatment is enough to finish the treatment. Okay, I funded the research service in orthodontic, the research area of our university. We treated a lot of craniofacial syndromes, craniofacial cleft palate patient, different types. And nowadays we are working a lot in sleep apnea, hypopnea in kids and also in adult patients. We use different types of appliances. We combine the surgery with fixed appliance, rapid maxillary expansion, functional appliance. We combine all types of appliances to for the best development of the craniofacial growth of our patient. This is the students for the master degree, for the 3 years full-time master degree. And I think it's very, very important this. I am a professor from the university. I am chairman, but the most important in my life is my office. I work almost 3 or 4 days a week, and more or less I see in a week, normally, I see in a week more than 300 patients, okay? And I think it's very important because I am a clinician. Okay, now I am developing the multi-technique. What is the multi-technique? It's a technique who combine the diagnosis protocols. We have our diagnosis protocols, the treatment protocols, and we development the synergy and the straightwire low friction wires for the fixes for the fixed technique. We use the micro implant system with the Thiacom company. We development the use of aligners in adults, but the most important for me is the aligners in kids. The use of aligners in kids for the eruption and proprioception guys and aligners. And this is with Alinea Dent. Alinea Dent is a very huge digital orthodontic laboratory in the south of Spain, in Malaga. The name is OrthoPlus, and Alinea Dent is the brand of the aligners. And the digital functional appliances. In my opinion, in the next years, we are going to see an expansion or a new ideas about the digital functional appliances. Thanks to the digital records, it's possible, and the digital print and the three-dimensional print machines, it's possible to manufacture and to design and manufacture new functional appliances. The use of the scenery with the gum metal is in my opinion, is a revolution in the field of the fixed appliances, because it's possible to use with 90 by 25 gum metal wire. It's possible to do 80% of the treatment only with 1 or 2 wires. The next, the use of the orthodontic microimplant. This is our new system of the microimplant. In my opinion, is very important, the extra-alveolar microimplant, because the extra-alveolar microimplant is an excellent appliance to treat adult patients, to do orthopedic treatment in young people, but also orthopedic treatment in all patients, because it's possible to do orthodontic treatment changing the alveolar bone beyond the apex of the teeth. And the use of the eruption proprioception guides. What is this? This is like a glove. Okay, we have guys, and we connect the teeth into the bone and control the eruption of these teeth to the best fit with the opposite teeth and to get the best occlusion. Okay, the Rocky Mountain Orthodontic Company is Rocky Mountain is from Denver, is the straight wire low friction. And the question is, what is the best bracket? This is the first step. Okay, a lot of companies talk about the self-ligating brackets, miraculous brackets, something special brackets. And the first question is this: do you have enough knowledge about the bracket design? Because the bracket design is not a very good topic for a lot of orthodontists. In my opinion, the objective of our treatment with fixed appliance is reduce the treatment time, reduce the arch wires, reduce the expenses of our office, and I think after coronavirus is very, very important, reduce the expenses of our offices. Aligners is very expensive. Most of the self-ligating technique is very expensive. And I think it's very important the control of the expenses. Give a good service to the patient and adapt to the wishes of the patient. Reduce the treatment time, it's possible to control or to break the biological or the biomechanical limits. The biological is very difficult because remember that the orthodontic tooth movement is an inflammatory process, is an inflammatory response of the periodontal tissues of the use of brackets, wires, aligners, removal appliances, functional appliance, and the most important is the vascular activity. Okay, for this reason, it's very important to understand the need of oxygenum, the hyperoxing or epoxy of the remodeling is affected. For the reason, it's very important to understand this. For the best biomechanics, we have to control it's like a car, like a sport car. The engine, the car engine is the coil spring, the elastic change. The car body is the bracket, and it's very important the coordination between the bracket or the car body and the engine, and the ligature represent the car wheels. Expenses is worthing to buy very expensive self-ligating brackets. A very good self-ligating bracket is better than a conventional bracket. This is a very interesting question. This is a patient who come to my office, and the patient is not is very happy with her orthodontist, but the patient said, "Oh, my teeth is aligned in the maybe 3 months to the start of the treatment, very, very fast with a very, very fast aligner of the teeth. But what is the problem? Why I am come here to Dr. Suarez? Because my problem is my orthodontist is not step by step the treatment. In the last 1 year, the orthodontist she do nothing in my mouth. Why? Because the problem of this patient is the overexpansion with night-type copper wires, with miraculous brackets. The miraculous brackets and the wires produce an overexpansion, and now it's difficult to say to the patient that the patient needs 4 extractions. Why? Because this type of office, I am thinking Damon office or another type of philosophy of treatment, recommend to avoid the extraction and say to the patient, "Oh, it's not necessary to do extraction. Forget to do extractions. No, extraction is an old-fashioned in orthodontic." What is the problem? The problem is this. And please remember this case. Remember this case. This patient is happy with the result of the result of the treatment. But what is the problem? The problem is this. I take a CBCT, and you can see this. You can see the disaster. All the roots are outside of the bone, outside of the bone. And this is a huge problem, because it's a huge problem and present a lot of legal, and you are going to the court with this patient. It's possible $70,000 or euros for this complete disaster. I have to extract 4 premolars. I have to change the torque of the roots and to move the roots to the cortical, from the cortical bone to the middle of the bone, to positive torque. I give a positive torque to the roots to put the roots another again inside of the bone. Please remember this. There is not miraculous brackets. According with Kevin O'Brien, I recommend to read this article from the American Journal of Orthodontic and Official Orthopedics, the magazine, the journal, 2010. In the land of no evidence, is the salesman king? I think it's very, very interesting, because a lot of companies say lies about the brackets. Okay, it's possible to use conventional bracket. Yes. What is the effect of the conventional bracket? Maybe the conventional bracket is a very excellent bracket to finishing the case, and the control of the torque and the control of the second and even the third order bends. What is the problem with the conventional bracket? The main problem is the friction. When you try to introduce rectangular wires at the beginning of the treatment, 90 by 25, and remember the new wires, TMA, thermal wires, gunmetal, when you try to introduce this type of wires into the slot of these brackets, present a problem, and the big problem is the friction, okay, the friction. And the friction is not only during the sliding mechanism to closing the space or to distalize the molar or to distalize the premolar. The main problem of the friction is at the start of the treatment. Why? Because binding and notching avoid is impossible for the binding and the notching to introduce at the beginning of the treatment rectangular superelastic wires. Okay, this is the theoretical movement of the root in a bracket in a conventional bracket, when you try to introduce a superelastic rectangular wire at the beginning of the treatment. The next problem in many cases is the friction. When you ligate, and I agree with Dr. Damon about this, when you try to ligate the conventional bracket with a silicone or with elastic ligature, with a plastic ligature, the main problem is the friction in the neighbor teeth to the canine. If you are using not a very good thermal wires, if you are using, for example, nitinol or conventional 90, not superelastic nitinol, the next problem is this: the protrusion of the upper incisor, the tendency to the open bite instead to get down the canine. And I think it's in this moment, yes, it's okay. Now it's perfect. And now it's perfect because you have now a lot of friction in these teeth. And remember that the conventional bracket with the metallic ligature is an excellent appliance when you are talking about finishing. And the opposite is the passive self-ligating bracket. In many cases, you have a lot of problems to finish in the case because it's not very easy to control the torque. For this reason, we have a three-way and a new way different to the conventional bracket and different to the self-ligating bracket. And the name is straight wire low friction. The name of the bracket is Synergy. The Synergy present versatility, simplicity, price, and present 3 pairs of wings, biconvex slot, and 3 rounded slot. Okay, different designs. They present the different designs to the conventional bracket and present, and I think is the most important, a different slot. And the different slot is a biconvex slot. With the biconvex slot is different the effect of the mechanic of the bracket of the Synergy. When the tooth is straight, of the tooth present inclination at the beginning of the treatment. For the reason you can see this photo, I take this photo in my university, in the laboratories of my university, and you can see the perfect adaptation of the 90 by 25 thermal wire to the special design slot of the Synergy, and present and avoid the binding and the notching, diminishing the time, diminishing the effectiveness of our appliance, and the most important, retarding the orthodontic tooth movement. For the reason the different design and different slot is possible to the early and fast insertion of 90 by 25 rectangular arch wires. We ligate in the center when we need minimum friction, maximum sliding at the beginning of each arch wire. In the conventional way for the medium friction to the maximum control of the second order bends, and we use this at the end of each arch wire. And when we need maximum friction, maximum control of the torque, for example, imagine at the end of the treatment for the control of the upper incisor, for the control of the upper canine, after the treatment of a canine included in the palate, for the control of for special cases. In this case, we ligate in a figure of 8, like a cross. Okay, for example, in this patient, we ligate in the middle because we need in this part of the mouth, in the area, in the premolars and the canine, maximum sliding, maximum backward movement and free movement of the wire. But in the front we need maximum control of the friction in the upper incisor to avoid the open divide, and at the level of this canine, for example, we ligate in the conventional way because the first objective of the treatment of this tooth is the control of the rotation. Okay, you have here the Synergy with a special design. When you put the rectangular arch wires at the beginning of the treatment, 90 by 25, 70 by 25 in many patients at the beginning of the treatment, you reduce more or less 40–30% the start of the treatment, the length of the treatment. And when you put the wire in this way, this rounded areas of the slot diminishing the initial friction angle. And I think it's very, very important, this biomechanical concept. Next step, the tooth is straightening, and you can see now with the same ligature in the same phase of the treatment, now we have a complete different biomechanics. Now we have a friction-free bracket. For the reason when we are using the synergy bracket, when it's possible to introduce rectangular wires at the beginning of the treatment and the different movement of the roots of the teeth thanks to the special design of the slot. Compare the root movement with synergy with the root movement with a conventional bracket, but remember, in the 90% of the self-ligating brackets present the same or have the same slot design than a conventional bracket. In fact, a lot of self-ligating brackets is only a conventional bracket with a tap, with a cap. Okay. For example, you have two tooth. Okay, when I ligate this in this way, the friction is increased. When you ligate in the center, diminishing the friction. For this reason, you have different types of orthodontic tooth movement and different control of the anchorage of the case according with the ligature. Something very simple, only and very cheap, only changing the ligature, put the ligature in one way or another way, is possible to control the orthodontic tooth movement tooth by tooth. Okay, for example, in this case, we need to move this incisor, the 21, the number 21, the upper left incisor to move mesial, okay, and in the ligate in this way, because in this way we have a low friction, and the movement is different than the movement of the other central incisor. Or in this case, we have to get down an upper canine without effect in the incisor, without effect in the premolars. I need first one thermal super elastic wires. The type of the ideal wire, the deflection of the wire is completely independent of the force of the wire. The force is more or less constant, and the deflection of the out of shape of the wire is different. Okay, I put ligatures here in this way. Why? Because here I need low friction for the sliding of the wire to the back. If I need 100% of the sliding of the wire in the back, it's possible to ligate the upper incisor in a conventional way like this, or we ligate with a lace, like a wire to join the 4 upper incisors. Okay, you can see here, you can see the orthodontic tooth movement. And now is a very important part of the treatment, is the finishing. For finishing, we need an excellent control of the torque. For the excellent control of the torque, we need the control of the root. And for this reason, we need to ligate in the conventional way to increase the friction in all teeth. Okay, when I need to distalize a canine, for example, in a patient with extractions, put the ligature in the middle of the synergy of the bracket of the tooth to move very fast into the back, because with this type of ligature is more effective the orthodontic tooth movement. The next question in our multi-technique, in the part of the multi-technique we are talking about the brackets, about the metal bracket, about the multi-technique with brackets, is the evolution of the wires. We are using many years ago stainless steel, the classical 19-all, and remember, it's like the model of the different phones, okay? The austenitic 19-all, the early austenitic 19-all. By today, we have to select the austenitic 19-all. It's possible to select the temperature. It's possible to select the flexibility. It's possible to select the force. It's possible to select the force independent to the size and the caliber of the wire. It's possible to introduce another alloys or another materials in the alloy, like a copper, to increase the effectiveness of this wire. And today we have the intelligent foam mobile, and we use the gum metal. Gum metal is a new alloy, something similar to the beta 3 titanium, to the TMA, the titanium molybdenum, the titanium niobium, similar to this metal, but with its excellent properties because presenting a spectacular elasticity, a spectacular flexibility, and it's possible to bend and to work and to bend into the mouth. It's very easy to work with this wire. It's possible today with the gum metal, the dream of angle 1 century ago, yes. Maybe this dream of angle is maybe to do all treatment only with one arch wire. And today is possible with the gum metal. Gum metal presents another advantages. One advantage is maybe gum metal needing a special type of bracket. The scenery bracket was not designed for use with gum metal because was designed more than about 15 years ago or more. But it's a casualty, but it's very they fit very well the slot of the scenery bracket with the new alloy gum metal. For example, you have this is a gum metal. I need to straighten only one tooth, in this case the canine, but I don't want another parallels or forces or another different forces in the incisor or the premolars. Okay, very simple. I ligate with a metallic ligature for the maximum expression of the wire in this tooth, and I put ligatures in the middle of the slot. In this case, you can see here the ligature doesn't contact with the wire. The wire remains free, and the effect and the rest of the teeth is a less small effect. You can see the straightening, the very fast straightening of the canine, and now we are using 90/25 stainless steel to finish the case. Okay, this is the gum metal, present titanium, vanadium, zirconium, niobium, molybdenum, tantalo, a lot of alloys, and present a conventional metal, the different type elements, the spectacular modulus of Young, the tensile stress, okay, the high stress is in spite of its low Young's modulus. This is a paradox property of the gum metal, present a high flexibility, non-linear elastic behavior. For this reason, it's very interesting the compare the bend alloy or the TMA with the gum metal. Okay, and it's excellent to treat cases like this with open bite. Okay, I use a lot for the open bite nowadays the mini screws. Okay, the micro implants, but in cases it's possible to use this type of curve of speed. A lot of people like very much the technique of Sato or different professors with a lot of loops is not necessary. With the gunmetal, it's not necessary to do a lot of loops. Only curve of SP, put crimp over hook, maybe 1 or 2 loops between the lateral incisors and the canine, between the canine and the premolar is enough. Okay. Here you have the open bite. The open bite. Now put the brackets. Put the brackets in the right and in the left. Okay, put now the curve of SP in the upper and the curve of SP in the lower. Okay, the elastic to engage the incisor, and the curve of SP in the back produce the intrusion of the molar and the premolars. We are using the crimp over hook between the lateral incisors and the canine, and you can see the result of the use of the gunmetal without extractions. Another more difficult case, this is a complete open bite case. In the patient refused orthodontic surgery. The patient was to the clinic, the people who use the Roth philosophy, and according with Roth philosophy, when you check this patient in centric relationship, you can see the contact at the level of the second molars, and the people need, according with the Roth philosophy, this patient need orthodontic surgery. Okay, I use a lot mini screws. I use a lot elastic, intermaxillary elastic, and I believe a lot in the dental-alveolar growth to treat patient, even adult patient, with orthodontic surgery. Why? Because orthodontic surgery, what is the situation in Russia or in other countries, is a huge problem. And in my service, in my orthodontic service, orthodontic surgery is free for the patient. It's free. Even when the orthodontic surgery is free in the National Health Service in Spain, in our excellent maxillofacial service with a lot of excellent doctors and excellent surgeons, even in these cases, the patient refused orthodontic surgery. Imagine if you treat a lot of patients, like Roth recommend, with orthodontic surgery, you have a huge problem of clinical success. What is clinical success? Is to get patient and to bring new patients. And you need very simple techniques. We try to avoid the orthodontic surgery and even to try to avoid extractions. For this reason, in this patient, this is a patient with centric relationship. I recommend in this patient, maybe it's possible to need a orthodontic surgery, maybe an impactation of the maxillary, Lefford 1. But in this patient, I treat this patient without mini screws. Today, I use all these patients with mini screws, but without mini screws, put brackets in the upper and the lower, and the secret is this gunmetal. Make these bands between the lateral incisor and the canine, using a lot of intermaxillary elastic in the back, intermaxillary elastics in the back to engage the occlusion. This is a huge advantages. It's possible to bend in the wire into the mouth. It's bending the wire into the mouth thanks to the use of this plier. Okay, to squeeze the wire in this point to produce the intrusion of the upper incisor, and with the elastic produce a good occlusion in the posterior part of the mouth of the patient. Okay. Okay, you can see here the gum metal. Okay, you can see here the gum metal. Okay, the patient during the treatment, the use of the gum metal to produce the intrusion of the incisor and destruction of the canine and premolars, and the end of the treatment, and in the patient years after the treatment. Okay. Another type of, and the patient years after the treatment. Another type of patient is like this. The problem of this patient is the shift to the upper midline to the left, and the main problem is this: the lack of space for the upper left canine, the lack of space for the lower right canine, shift to the upper midline, okay, to this way, and shift to the upper midline to the right in the opposite way. Okay, the treatment of this patient with extractions, is very difficult. With extractions, why? Because you need to extract first in one side to move this canine to distal. Okay. In the lower, the same is very difficult. First is the extraction of this tooth. Second, to move the lower midline to the other side. But the treatment without extractions is very simple. In these cases, I start the treatment with a rectangular thermal wire and put the coil spring between the lateral incisor and the molar. I like very much this. I realized that Damon Technique used something similar, and I like very much because this is a very simple technique. Only use a wire, a coil spring. With this coil spring, you get first protrusion of the upper incisor. Second, a little distalization and disrotation of the upper molars. Third, get a lip bumper effect in the eruption of the premolars, in this case, in the upper arch. For this reason, I use a lot this type. Put open with a ceramic burn. I use, it's possible with a laser or with a ceramic burn. I open a small window in the gingiva, okay, to produce the traction of the canine. Use a coil spring, and now it's time to use a rectangular 90 by 25 wires, short and heavy elastics to control the torque, to moving the roots and to give to the roots a negative torque. Remember that if you need expansion, you get the expansion with the arch wire. Forget the brackets, forget the torque. It's a mistake. You get a nice smile, a Hollywood smile, a full smile, thanks to the expansion of the arches, okay? If you produce a lot of expansion at the level of the arches, you need the opposite. You need negative torque at the level of the premolars and the molars. You need negative torque. The negative torque is the result of the negative torque is thanks to the combination between the torque inside of the slot, or if you prefer to put the torque in the wire, to bend in the wire, and second, the use of intermaxillary elastics, short and heavy. The end of the treatment, you can see, thanks to the PowerPoint, a superposition between before and after the treatment. open the space, distalization of the molar, incisal side shift effect of the incisor, expansion, and disrotation of the molars. The patient, years after the treatment, okay. Another patient, and multi-technique, remember the name, multi-technique. This is a patient with a class 3. What is the best appliance to start the treatment in this patient? Okay, the patient presents a very good transversal relationship in the upper arch. It's not the best candidate for rapid maxillary expansion and facial mask. For this reason, the patient presents a very huge shift, functional shift to the mandible forward. Okay, a huge discrepancy between the centric relationship and habitual or common occlusion, not maximal intercuspidus. For this reason, is this patient, the first step for this reason is multi-technique, is to use a very nice appliance. And the nice appliance is the progetic or class 3 active removal plate. The active removal plate. Okay, the design of this removal is very important. The first step is this. Please forget low quality wires for the removal appliances. For the removal appliances, the technicians use a very bad low cost wires. Very bad stainless steel. Please, I use for these wires, I use the LG Lloyd wire or even TMA wire. Why? Because we need a lot of elasticity. We need a lot of elasticity to move backward the lower incisor. At the same time, this appliance, this wire, produce the forward protrusion, the forward movement of the removal plate and the protrusion of the upper incisor. Bite blocks, very important, the vertical control in the posterior molars and premolars, and this space is the space for the eruption of the upper incisor and the eruption of the lower incisor. The control of the eruption of the incisor, respect of the control of the eruption of the posterior teeth, in my opinion, is very important. You can see the removal plate. The removal plate we divide the removal plate in 3 parts. We are using from Leone, from Italy, the screws. 3 screws for protrusion, for expansion to the right, for expansion to the left, and the wire. We use this appliance about more or less about 6 months. 6 months is enough to correct the anterior crossbite and to correct the vertical dimension. Next step, I love the utility arch. Put my brackets, I like the scenery bracket, and combine with the protrusion utility arch. And in cases like this, I use the chin cap, but the chin cap, I don't use the chin cap like in orthopedic treatment. I don't believe a lot in chin cap when I try to do orthodontic treatment because the problem is the cooperation of the patient. It's necessary for the orthopedic treatment effect a lot of hours, maybe 18 or 20 hours a day. I use the chin cap in this patient only to get the mandible as close as possible to the centric relationship, or as close as possible to the centric relationship. And now it's time to the straight wire low friction. It's time to put wires, to put brackets. Okay, it's very simple. Now it's very simple. It's very simple. It's very important to have brackets and wires to reduce the time of the treatment with brackets and wires. We use functional appliance first, and second, finish the utility, and finish the treatment with engage the occlusion. Okay, now is the occlusion of the patient and the face of the patient. Very fast treatment and very simple treatment. Okay, this is my group of strike wire friction around the world. I in the EOS Congress. Okay, with the different friends around the different countries. I have now about 30 groups in the world with Tony Thacken, the president. This is unfortunately, this is in Lebanon, in Beirut. It was a disaster yesterday. Okay, in North America, in South America, in Brazil, in United States with Tony Thacken, with the different professors from universities from Canada, from United States, Carl Eugenio, the famous Carl Eugenio orthodontist from Rikes Technic, in Asia, in Europe, in Poland, in Ukraine, and here is in Guatemala, in United States, and I have a lot of groups and courses in different universities, in Nicaragua, in Ecuador, Hong Kong, and one of the most biggest groups of the strike wire friction is in Philippines, in Manila, with the group in Ulaanbaatar. We start to introduce the technique in Ulaanbaatar 2 years ago with a very successful result. I like very much the hand-on courses, the practical courses in Jordan, with the functional group, the functional appliance group, in Kiev, in Ukraine, is in Orthodontic school from St. Petersburg, in Ukraine. Okay, and now it's a different grants in the University of Anterior Orrego in Peru, in University of Cordoba in Argentina, La Plata in Argentina, speak in Taiwan, and with my friend, he's the owner of OrthoPlus, Jesus. Is an excellent group, it's an excellent laboratory of aligners, of functional appliances, and now I am the director of the European Alinea Dent Academy with a different research group. We have a very huge private engineers group to develop different systems for aligners, different attachments, different type of functional appliance. During the American Association, I was in the past vice president of the International Association for Dental Research, the Orthodontic, and also we have my institute in Santiago de Compostela. I organize. I hope that we will organize after the pandemic intensive groups, intensive courses 1 week, and come a lot of people from around the world. It's a clinical center. This is the clinical, the courses, hand-ons, digital orthodontic, courses with patients. This is the area of the library of our center with the different magazines, the intraoral scanner, the scanner of the models, the digital, the virtual reality, the smile design. We focus our clinic in the smile design and the new system, the digital system to the diagnosis of the orthodontic treatment, and come to the different doctors from Spain, from France, Italy, from Ukraine. This is the group, our group of pediatricians. We have a very excellent group of the courses for pediatric dentistry with a new, complete new focus or a new different approach to the conventional pediatrician treatment. And this is people from different countries who come to our office. Okay. I wrote different articles in Spanish. Unfortunately for you, it's in Spanish in the Dental Tribune. Some of them is translated to English, and it's talking about the relationship between the design of the smile and the neuromarketing, the expert in orthodontics, what is the moment to start the orthodontic treatment. This is and we have a channel of YouTube. My name, Edwin Suarez Quintanilla. In the channel of YouTube, I have different videos, presentation in Spanish and in English, different types. And I think it's very important, my friends. Okay, this is the group of my friends, the students from different universities who come to my office, from the universities from Madrid, Barcelona, Valencia, from different parts. And this is my family, and this is my kid. I have five kids, and I am very, very, very happy. Okay, for this reason, it's very important to understand what is the idea of the multi-technique. Okay, remember this, more than 1 century ago, Angle, founded with Calvin Case, founded the modern orthodontic system, create the edgeways. After Tweed create the School of Tweed, very, very important. Andrews introduced the concept of the prescription and the concept of the strike wire. And Ricketts, in my opinion, Ricketts was one of the most important orthodontics in the history. And Ricketts introduced a lot of very interesting concepts about the design of the appliances, about the aesthetic of the face, about how to treat patients in mixed dentition. And I am going to talk today something about this. This is very, very important, how to treat patients during the mixed dentition period. After the excellent group of Roth introduced the concept about the TFG, about the occlusion, MBT, introduced a very good mechanics, the mechanics step by step during the treatment, new device, new appliance, aesthetic device, new types. In the 2000, start a new current, a new way in the orthodontic. Very important, not only in orthodontic, in general, in medicine, is the evidence-based orthodontic or evidence-based treatment. And the base of this treatment is this pyramid. This pyramid is very, very important. It's very important to analyze what is the quality of our base, the basis of the profession. Okay, it's different. The meta-analysis completely different than the individual case report or information about the speakers or about the speaker who is in connection with a company or a commercial brand. For this reason, it's very important to understand this evidence-based orthodontic. We must to base in this evidence-based orthodontic our diagnosis protocols, our protocols of treatment, and the use of the biomechanics and even the use of the different appliances. In 2005, more or less, is put in fashion the new combination between super wires and the self-ligating brackets, two currents. The first step or the first to approach, the first is to use night-type copper wires and with a self-ligating bracket, with the passive self-ligating brackets, like the Damon is very, very famous, almost in Spain. And another type of combination between super wires and the bracket is the synergy. The synergy, the difference between the synergy and the self-ligating bracket is the synergy present is possible to go with a self-ligating bracket in this case. Okay. Introduce the use of mini screws. Okay. Introduce in the mini screws and put the mini screws in the patient. Another big advantage is the use of the mini screws and the mini plates. For example, in cases like this, to use to close the bite. And about 2015-17, starting the use of the intraoral scanner, the use of the digital orthodontic, and now, in my opinion, digital orthodontic change a lot. Okay, change a lot. And 2020, okay, and 2020, more or less is the time before the coronavirus. Before the coronavirus, we are using the new aligners. The diagnosis companies, I think, the diagnosis company and the use of the memory shape polymers. The memory shape polymers. Okay, I think it's memory shape polymers represent the future of the aligners. Okay. Okay. For this reason, we have to understand the problem of the crisis, and the problem of the crisis nowadays is the massification of the patient, the massification of the number of doctors. I think it's very important to understand this. This is the change of the society, and the change of the society after coronavirus. Now we have a VUCA society: volatility, uncertainty, complexity, and ambiguity. Okay, volatility, speed of change, forces and change catalysis. Uncertainty, lack of predictability, surprise, and the sense of awareness and understanding of issues and events. Complexity, no cause and effect change and confusion. Ambiguity, the hastiness of reality, the potential for misreality. Another problem is the dental franchise, the insurance companies, and the change of big dental companies. The truculent marketing of these companies is the fake low cost. It's not real low cost. And adaptation to new digital technologies and the use of aligners, okay, and the use of aligners for the general practice, for the general dentist, okay. For this reason, we have a lot of professional weakness and threats, okay. We have a lot of professional weakness and threats, and we have a huge crisis. And the huge crisis included the online shopping, the companies like the Smile Direct Club to try to sell aligners by shopping, by online. And this is the old situation. In the old situation, we bought a Damon, Onco, muscle, or we have a lot of materials, and my training, brain, and hands are my capital gain. And normally, I bought a material, brackets or wire, and multiply, thanks to my work, for 10. Okay. Today and tomorrow, we are using Invisalign or are using another type of appliance, and the idea of a lot of companies is to eliminate the orthodontist and even to eliminate the general dentist practice. And the idea is to create the clinics to sell directly to the patient the aligner and the appliance. For the reason, in my opinion, Smile Direct Club or another companies put this in the professional orthodontists. Remember that this is very important. Maybe today you are the best dentist in the world, but tomorrow you will wake up in a world that doesn't not exist. And I think it's very, very important to understand this. I think it's very important for the successful of our clinic to understand a lot of topics. And for this reason, multi-technique, including marketing, including a new focus for the patient, a new focus for the doctor who works in my office. The patient uses us more for our empathy and the quality of our service than for the quality of the treatment itself. And I think it's very, very important for the clinical success. The best dental service are not a product of the dental science, and the patient is not concerned with how much you know, but it's very important for the patient how much you care, how much you are in a good connection, in a good empathy with the patient. For this reason, I have to be able to do a good treatment, to do an encourage planning, to use a good biomechanics, to give us an outstanding service. But I think it's very important also to sell smiles, to sell smiles. And for this reason, are you a good salesman? Okay, remember this is because this is very, very important. You will be here for more than 70,000 hours in your life. And I think it's very important. Be happy in your office. A lot of colleagues, my colleagues about 60 years old, present the burnout syndrome. And the most succeeding occupation are, you can see here, the dentist. Dentist is the third position. Okay. What is the problem? The first problem is this, the business of our profession. Okay, the business of our profession. And the second problem is the new digital focus of our treatment. Remember this, the success is not the key to happiness. Happiness is the key to success. Be happy in your office. Where are you going every day? Where are you going every day? You are going to the heaven of your office. Doctor, I am very happy with my treatment. Or you are going to the hell of your office. It's harming, it's burning. When do we finish the treatment? My son is suffering. Okay, is this your practice? This? Okay, it's very important to organize very, very well your office. And what does the patient want? Good service, comfortable appliances, fast treatment, few appointments, aesthetic appliances, high quality and cheap. Okay, and for this reason, it's very, in many cases, it's very difficult to offer to our patient treatment like this. Okay, for online shopping, to take the impression or to take the intraoral scanner in the office and give to the patient all the aligners. Okay, I think it's very important to avoid this type of companies and avoid this type of practice. And it's very important because the online shopping is growing, growing, and growing in the millennials. What is the problem with the crisis? With the crisis, we have this is the topics of the lecture for today and for the next of the days. We are talking about our orthodontic practice after the coronavirus, clinical success in efficient orthodontic, occlusal objective in orthodontic, static and dynamic, the diagnosis and the treatment plan, the facial and smile digital analysis, the cephalometric analysis, dentofacial growth, facial pattern and vertical control, smile design, and types of appliance in our technique. For this reason, this is the topic for today and for the next day. Okay, this is the topics. And I think it's very important to understand for the new orthodontic to understand, even for the new smiles, what is the difference between the rational purchase and the emotional purchase. If you are going to abroad, to another city, and need to buy a bag, it's completely different if you buy this bag or buy this bag. Why? Not only for the price, is this bag is practical, comfortable, and good value for money. Okay, this is the objective to buy this bag. What is the objective of to buy this bag? Is to get status, is to get a new experience, and to get new emotion, even to get better self-esteem. For the reason, this is the two types of patient in our office. This is the practical or rational patient. The rational patient only looks in our office the solution of a functional or a pain problem. And this is the emotional patient. Emotional patient is going to my office to change her or his life. Need to change his life through to get a new smile. When the patient get a new smile, change the self-esteem of the patient, change the emotion of the patient, and introduce the happiness in her life. For the reason this is a rational patient, emotional patient. What is the difference? The most important difference is the money. This patient pay a lot of money for this bag, maybe 10 times the real value of this bag, 10 times the real value of this bag, thanks, and the patient pay for the emotion, pay for the status, pay for the experience, pay for the self-esteem. This patient is completely different. Only use something practical, good value for money, and more or less comfortable. For this patient, this bag is nothing in his or her life. For this patient, for this customer, this bag is very important in his or her life. Rational patient, okay, needs something to treat, something to produce pain or functional problems, seeks to solve a pain or functional problem. And this is an emotional patient. Emotional patient look for something else, self-esteem, status, happiness. A very good example for the girls is the whales, the shoes whales. Okay, like a shimmy shoe. Please check these shoes and check in internet the sentences about these shoes. The price is very high. Why the people pay a lot of money for these shoes? Only for emotional reasons, not for practical reasons. In Spain, in Spanish language, is the same. And for this reason, very important, what everyone's give, we need to focus and what make you different. Forget this type of change of clinics. Forget the low-cost clinics. Forget this type of style to work. You must focus in what make you different. In my opinion, there is, after coronavirus, two types of office style. The caries office style and the smile design style. The caries style to treat the caries and the result of the caries. A smile design, completely different. And if you are orthodontist, it's possible not only a smile design, it's possible to create the face design. Who understands the malocclusion? Imagine this patient. The ideal result of the treatment of this patient is this. Align the teeth, close this, extract first, the radicular rest, close the space, align the teeth, put the implants here, okay? And I think it's a very, very good result, but it's not the correct treatment or the common treatment in 90% of the clinics in the world. Okay, why? Because the dental general practitioner, the GP doesn't understand the malocclusion because doesn't understand orthodontic. Nowadays, with the different records, the patient come to my office with the records of the 3D records, with the occlusion records, with the TMG records, with the 4-dimension Plameca sagittal records, with the, okay, and we need to understand all the records. In my opinion, can the general practice without orthodontic knowledge to do a good plan of treatment? In my opinion, no. In my opinion, it's very difficult. For this reason, more than 80% of the general dentists don't have enough knowledge of orthodontic for the diagnosis of orthodontic to do a very good rehabilitation. Why? Because maybe, I don't know exactly the number, but maybe 80 or 90% of the patients who come to the clinic with a to look for a rehabilitation. Okay, this high percentage of the patient present severe malocclusions, class 2, crowding, deep bite, and it's impossible to treat very good this patient without orthodontic treatment. Okay, without that. For the reason, in my opinion, in the dental, not in orthodontic, in dental, Houston, we have a huge problem because for the most of the rehabilitation need for the doctor orthodontic knowledge. And we are talking of orthodontic knowledge about the diagnosis. For this reason, in the future, the old-fashioned is GP with ortho, and the other is the smile design perio, GP, or pedodontics. Okay. For this reason, it's time to evaluate our office. The crisis generate an opportunity. It's time to do a plan, a vision, mission, objective, strategies, and action plan. And for this reason, in my opinion, it's very important the technician, the information, the aptitude. But in many cases, the book of orthodontic is like the bricolage. It's like a course to do something step by step. My objective of my lecture is to do technical information, to change the aptitude, to give concept and to change the attitude, to create a new concept and emotion respect to the orthodontic. And for this reason, it's very important this. What was my objective with my master students? Okay, one minute. I am going to come back. 1 minute only. Okay. Okay, and what was my objective with my master students in the past? In the past my objective was to introduce all the knowledge. This is my book. Unfortunately, it's in Spanish. With the idea is introduce the knowledge of this book and the biomechanics about the analysis, plan of treatment to introduce in the brain of my students. But what is the most important in our office? Remember, this is in the past. In my opinion, the most important in our office, and most talking about the crisis and talking about the crisis after coronavirus, is the clinical success. What is clinical success? Is to bring patients who bring other patients. What are my objectives today with my students? The first is clinical success. The next is orthodontic knowledge. And the third is critical thinking. I think it's very important to analyze the information that the students receive in courses, seminars, or from the orthodontic companies. What is the future after the coronavirus? It's possible to use to use a lot of aligners, Invisalign, and to replace the aligners for the brackets. It's possible to get down the brackets. In the future, it's possible to combine. Okay, remember this. This is the first problem when you're talking about the Roth technique, the Ricketts technique. The first problem is this, in my opinion. Roth technique, tube technique, tip-edge technique, MBT technique Ricketts technique was created in the time of the Beatles, in the time of the Rolling Stone, even before. That time, the car in Spain was this. And nowadays, change a lot the cars, change a lot the technology, and even change a lot the Rolling Stones. For the reason we need to change our office. What is the ways, okay, and the ways and the roads? One is the classical orthodontic, using wires, brackets, even classical brackets, even conventional wires, alloys. Another type of practice is Invisalign or aligners, to use only aligners, or combine classical orthodontics with aligners in different patients, in the completely different patients. My solution is the multi-technique and combine different appliances in the same patient in the different phases of the treatment. Okay, for this reason, what is the philosophy of our technique? We are going to talk about our technique with a lot of clinical cases, no problem, in the next seminars. But I like very much to the first step in our life is to center the philosophical ideas of our life. What is the philosophy of our technique? The first, understand that the society and the profession have drastically changed. We have to adapt to the needs and demands of the patient. We have to know and combine different devices and techniques. We must be more eclectic and creative and less dogmatic. Open your mind to the new, simple, ecological, and cheap treatment. Please, 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 we can't be held hostage by aligners company. This is a huge mistake of a lot of colleagues. When a patient comes to my office with a little crowding in the lower incisors, okay, and the patient refuses to use the brackets and wires, I put a removal appliance. The price of the removal appliance is 90, okay, euros, and the patient pay me 1,000 or 1,500 euros. This is a very profitable practice. A smile must be the center of our office. Most emotional patients come to our office to get the best Hollywood smile. The smile design is associated with neuromarketing, something very important in the new times of after coronavirus. Digital setup and mock-up are excellent weapons to turn a rational patient in emotional patient. Neuromarketing uses the brain technologies such as the functional magnetic resonance imagings to study the brain response to market stimulus. And remember that we have in our brain three parts. The most basal part or most old part is the reptilian or basic function. In the middle, around the amygdala or the cumbus nucleus, is the limbic system. The limbic system is for the emotional response, and the third part is the cortex. And very important, the prefrontal cortex. The cortex was described and written in a very nice draws for the Santiago Ramón y Cajal from Spain, Nobel Prize in 1996. We have the continuous, the rational and reasoning, thinking, intellectual, the unconscious, no conscious control, automatic nervous system, control the breathing, heartbeat, control of the digestion, and the subconscious is like our hard drive for the feeling and the emotions, the behaviors, the habits, and the permanent memory. And I think it's very important, this book, the Thinking Fast and Slow. This is Daniel Kahneman, is a Nobel Prize laureate for the economist. This is Kahneman talk about the system 1 and system 2. What is system 1? It's a fast system to thinking. It's instinctive and emotional. And system 2 is slower, more deliberative, and more logical. It's very important this in orthodontic or in dental smile design, because a lot of patients thinking with the system 1 when we are talking with he or her about the treatment for veneers, for orthodontic treatment, for blanching, for different smile treatments. 90% of the time work with a fast system, with a system 1. And it is full of prejudice, false perception, stereotypes, and halo effect. This is the system 1, when you are going to the everyday decisions, automatic and fast. And the system 2, slow, effortful, conscious, complex decisions in our life. And I think it's very important to understand this. What is the difference between a rational patient versus emotional patient? Emotional patient, remember the back, do not buy what they need, buy what they want. I think it's very important. For the reason the patient come to our office and desire a white smile with big teeth, with big lips, with a very protrusive lips, with a very spectacular and whitening smile. It is important even to sell treatment in our office. For example, when I have to sell a periodontal treatment, it's very important to sell the periodontal treatment to the cortex of the patient, to the rational part of the brain of the patient. Why? Because this is the periodontal treatment is a rational decision of the patient, because the patient understands now, after our explication, that they present a disease. The disease is a disease of the bone, a disease of the gingiva, and it's possible to lose the teeth. And the patient and the people are afraid of losing. For this reason, in the casino, they use the different pieces of plastic, and a lot of dentists and a lot of people need a guarantee or want a guarantee for lifetime. But when I need to sell a cosmetic treatment, please don't sell this treatment to the rational cortex of the patient. Don't explain to the patient how is the treatment, how is the feeling the teeth. No, it's completely different to sell. You need to sell the treatment to the emotional part of the brain, to the limbic system. You need to sell. Why? Because it's completely different to the periodontal patient. The patient that wants a new smile, wants a new emotion, a self-esteem, a happiness, a new feeling. And for this reason, remember the emotional shopping. Fortunately for orthodontists, fortunately for the aesthetic dentistry, it's the same like the back. It's possible to increase the fees a lot thanks to we are going to sell emotion, we are going to sell feeling, we are going to sell happiness, not only to sell white teeth or aligned teeth or a new smile. This is the same, the halo effect is a person making an initial assessment of another person. It's a cognitive bias. will assume the ambiguous information as upper concrete information. For example, when the patient smiles with an attractive smile, presuppose other values like youth, social status, smartness, loveliness, wit, sexual success, etc. This is the famous halo effect. And a lot of patients who come to our office and pay a lot for a new smile looks this new smile for the halo effect. It's the same like the people who buy the boots of Ronaldo or the racket of Nadal. Okay, this is an association between the boots and the quality of the football player. The association between Nadal and the boots. It's the same like this. You see these patients with a very nice smile. You are thinking in what? You are thinking in happiness, successful, okay, very nice life, very high status, very happiness people. And I think it's very important because remember this, when the patient come to our office for beginners or orthodontic, emotional patient do not buy what they need, buy what they want. Okay, for this reason it's very important. And this is very important. Why? Emotional patient represents only 20% of our office, not in orthodontic. In orthodontic, we have more emotional patients. But in a normal clinic, in a normal office, emotional patients represent more or less 20% of the patient. But the profit of the 20% of emotional patients represent 80% of the profit of our office. For this reason, digital technology helped us to transform the rational patient into emotional ones. How to transform rational patient into small ones? Because you need to wash the brain of your patients. You must to transform, to turn to rational patient into the emotional ones. This patient come to my office many years ago and asked me, I would like to have a nice smile, please, I need a treatment. Okay, I start to talk with the patient, and I am going to talk with the rational part of the patient, with the cortical part of the patient, with the cortex of the patient. And we are talking about it's possible to do orthodontic treatment. Oh, no, I don't like, say me the patient, I don't like the orthodontic treatment with brackets. Okay, it's possible to put aligners. Oh, no, I don't like the aligners because I need to put the aligners 24 hours or 22 hours a day. Okay, it's possible to put lingual brackets. Oh, no, I don't like lingual brackets because it's hurt my tongue and it's very difficult to talk. Oh, it's possible to put veneers. Oh, no, because do you understand this type of the patient? Okay, a very, very complicated patient. What is my problem? It's not a problem of the patient, it's my problem. I am talking to the cortex of the patient, and the patient is using her cortex, okay, to talk with me. It's the classical no patient. It's very difficult to talk with this patient. Okay, for this reason, we did decide to talk with the patient and said, oh, no problem. I am going to make a DSD, digital design of the smile. We're going, the first is to analyze the anterior boundary of the smile. The second is the upper incisor position. The third is the skeletal problem. The fourth is the dental problem. The five, etc., etc. The first point is very important. The first point is to analyze the position of the upper incisor, the relationship between the upper incisor and the nasolabial angle of the patient. The nasolabial angle is very, very important because the movement of the upper incisor and the skeletal movement of a point or the anterior part of the maxillary play a very important role in this special curve of the face. Okay, this is a very important part, and because the nasolabial angle depends of the upper lip, the upper incisor, the anterior part of the maxillary, the nose, and it's a very aesthetic part of our profile. It's a mark that indicates the protrusion or the retrusion of the lips. The nasolabial angle is like a lighthouse, okay, of our treatment, okay, to understand the treatment, the problem of the patient, and we change the nasolabial angle with a lot of our with most of the treatment. When you move the upper incisor, when you produce an orthopedic treatment of the maxillary, when you try to move forward the mandible, when you try to move forward the maxillary in a maxillary class 3, in all the cases, okay, we change a lot the nasolabial angle, especially the lower part of the nasolabial angle. It's very important to analyze the incisal guide, not only for the aesthetic, even for the TMG. Okay, a lot of TMG problems is in relationship with an inadequate incisal guide. Next step, analyze the overjet, analyze the overbite, the position of the upper incisor, the position of the maxillary. Okay, the inclination of the upper incisor respect to the true horizontal, to the true vertical, the protrusion of the incisor, because this is the first step. The people is very funny. You are going to a course of smile design. In 90% of the cases, you need to know orthodontic treatment, because the best analysis to know where is the correct position of the smile, the first step is to put in the correct position the upper incisors. The upper incisor, with the cephalometric analysis, indicate to us the adequate position of the upper incisors. Next step, for the smile design, in a lot of patients need expansion. It's impossible in many cases to avoid the black corridors. It's impossible to get a nice smile only with veneers, with composite. You need dental or even skeletal, but normally with dental expansion is okay. The interincisal angle, very important for occlusion, for aesthetic, and to determine and different analyze of the nose, of the upper lip, of the lower lip, and the overjet and overbite. Okay, the aesthetic analysis of the occlusion. Surface of contact, 50% between the central incisors, 40% between the central incisor and the lateral incisor, 30% between the lateral incisor and the canine. Bolton discrepancy. The lateral incisor must be 65–75% of the central incisor. Lower lateral incisor must be 90% of the lateral incisor. For this reason, it's very important the arch dimension. If the patient comes to your office and the patient presents 35 millimeters from molar to molar in the maxillary, it's impossible to do a nice result after the smile design without orthodontic treatment. Okay, I think it's very, very, very important. It's very important, all of this. Inclination of the second order bends, the torque. Remember, please, this is a mistake. A lot of people from different techniques have confusion about this and talk about the positive torque to the nice smile. It is a mistake, please. This is the ABC of orthodontic lecture. Okay? If you try to expand the maxillary to get a nice Hollywood smile, a nice smile, please use the arches to produce expansion, night eye, tiny steel, TMA, the arches to expansion, but you need negative torque, okay, to get a occlusion. Expansion with the arches is for aesthetic. Expansion is for aesthetic. Occlusion is for negative. Okay, arch. I think is very, very important. It's very important. Okay. Okay, next we are using the PowerPoint. Nemo Studio. You have a lot of programs, but I use PowerPoint. I like very PowerPoint. I love PowerPoint. PowerPoint is spectacular. It's free. It's very cheap, and it's spectacular in my hands at most for the smile design. Okay. After the smile design, prepare the ideal model. Okay. Put in a photo, in a digital photo, the ideal smile for this patient. And now in next appointment, this is an old case, many years ago, but it's very simple. This is the plastic. Put the plastic in the second appointment of the patient. Okay. Test in the second appointment. Vaseline. Put the composite inside the resin, put the resin, eliminate the excess, with a liquid composite, okay, adjust. And you can see now the patient in the second appointment. Okay, it's not perfect, but it's very good to show to the patient the new what? The new teeth, the new smile? No, the new face. Please, in your office, check the eyes of the patient. The eyes of the patient is the best test to know what is the result of your treatment for the patient. Okay? The eyes of the patient. Check the difference. Now, in the past, remember the first appointment. No patient. A rational patient. Oh, I don't like to do this. I hate orthodontic treatment. I hate lingual orthodontic treatment. I hate to use aligners. I hate to use veneers. I hate to blanch the teeth. And now we have a complete different patient, emotional patient. And now is working the limbic system. The working in progress for my treatment, for my fees, is the limbic system. And now the patient thinking, I need this treatment. Could you give me a credit? Okay, because this is the typical reaction of the patient. Another patient the patient with a lot of problems and work in a change of clinics. This is the businessman of work in a change of clinic. Very funny, but was really the test was very difficult because present a lot of lack of permanent teeth, a lot of agenesias, break and problems in the teeth. Well, okay, this is the treatment was with aligners and with removal plates. And this is the result. Remember this, don't talk about teeth, talk about happiness, because the people don't pay for teeth. The people pay a lot for happiness. Okay. Next question about our technique, philosophy. We are talking now about philosophy. Okay, in the next steps by step, the seminars, I am going to talk about the different biomechanics, the different diagnosis of each case. But now is the first step, because a lot of people when talking about technique, another technique is something very is similar to another colleagues. No, this is a different technique for the new times. Next philosophy of our multi-technique ideas. Be accurate in your diagnosis and simplify your treatment, and adapt your treatment to the wishes of the patient. I love the TMG patient. I love the TMG joint. I like very much, okay? Okay, this is a typical patient who comes to my office. I am not specialized in TMG, but I have a lot of patients with TMG problems. This is the typical patient who comes to my office. Oh, what is your problem? Oh, my problem, I have a pain here, close to the eye, to the, here in this area, in the ear. And, oh, yes, maybe you have a malocclusion. Oh, no, I don't have a malocclusion. I have a very, very nice teeth. Only have a little bit this, with a little bit outside of the side. But this is not, I don't like orthodontic treatment because my teeth is perfect. This is the typical rational patient. Okay. Excuse me for the Spanish, but when I have a patient with TMG, I divide the patient in 4 parts. TMG problems, intracapsular problems or muscular extracapsular problems. Occlusion, the question is possible this occlusion produce, or there is a relationship between the occlusion and the TMG? Central nervous system, or psychology. In this patient is very happy, forget the psychology. Don't present in the exploration, don't present problems at the level of the central nervous system. We take, doesn't present problems in the position of the meniscus, maybe a little bit luxation with reduction. And the occlusion, yes. The occlusion presents a nice class 1 in the right, a nice class 1 in the left, but present a retrusion of the central incisor, and secondary a retrusion and a condyle retrusion of the posterior teeth. I take a test with the roll of cottons to bite, to open, to close, to check the dental, the mandibular movement. And my first diagnosis is a retrodiscal compression. Why? Very simple, because when you put cottons here, cottons here, or a bite block, and the patient bite, disappear the pain or diminishing the pain, okay, of the patient. Maybe the first step of my diagnosis. The second step is the magnetic resonance of the TMG. But my first step is this. Diagnosis is the retrodiscitis, a compression of the retrodiscal area. This area is very rich in vessels, rich in nerves, and is very painful for the patient. Okay, now it's time of the treatment. What is the treatment in the 90% of the office? To put in a splint. Okay, to put in a splint. It's absurd to put in a splint in this patient because the first step is to move forward the upper incisors instead to use a splint, or using only in the splint for the splint in the weekend, maybe for the acute pain of the patient. Okay, but what is my idea? It's very simple to treat this patient and to move forward the upper incisor. But we have a rational patient. A rational patient. The patient don't understand the needs of orthodontic treatment. Don't like orthodontic treatment because the patient said me, no, my teeth is aesthetic. The aesthetic of my teeth is perfect. Only to have a little bit the lateral incisor a little bit with a not very good position. Okay. What is the solution in my office? Very simple. The price in my office are more or less about splint with mounting in articulator is about 300 or 400 euros. It's more or less the treatment, and the patient after this pay me for each appointment. Okay. And I said to the patient, okay, do you like the orthodontic treatment? No, like it's very expensive and I prefer to use a splint. Say the patient to me. Okay. And I said to the patient, okay, I am going to put something similar to a splint, but the objective of this new splint is not a splint, is to treat the problem and at the same time to improve a little bit the teeth. Okay. The price is more or less similar. The name of this treatment in my office is a tentative first phase treatment. What is the objective? The medical or therapeutical objective is to produce the protrusion of the upper incisor. Okay. At the same time, it's possible to move a little bit the lateral incisor backward with this spectacular and very simple appliance. We are talking about the 90 about the 90 euros only. 90 euros. This is the price. 100 euros, more or less. I put this, okay, and with this appliance, the first objective is to treat the TMG of the patient. But my second and very important objective is to change the mentality of the patient and to turn or to transform the rational patient in an emotional patient. Okay, this is a couple of screws. The cut of the removal plate is in this way. Okay, this is an excellent appliance if you like to avoid the use of Invisalign or aligners in the class 2 division 2. And I remember in Ukraine, in Poland, and Russia, You have a lot of patients with class 2 division 2, the typical class 2 division 2 in a brachycephalo patient. This is a spectacular appliance to start the treatment. Okay, the next step is this. Put in the lateral incisor an attachment with composite, the same color that the enamel of the patient, and we use these wires. This wire is possible to do these wires in white color, okay, to pressure the lateral incisor. And now, after the treatment, now it's very funny. The patient said, "Oh, I improved my articulator, but I improved my teeth. I am very nice, my teeth. Okay, I would like to do orthodontic treatment." Okay, and what is my trick? My trick is, okay, do you like the orthodontic treatment? Yes. Well, how much is it? I don't know. You may imagine this is 2,500 euros. Okay, but no problem, because I discount the price of your first appliance in the complete orthodontic budget treatment. Oh, and the patient is very happy and everything is very happy. But now I need to align a little bit best the upper incisor and use this very funny trick. These are white tubes. I put in the white tubes aesthetic wire, white. Now, this is a very old case. I have a very nice from Korea, from the South Korea. I have very nice white wires, or not cover, only the cover. The wire is white, and it's very nice. Okay, to align the teeth, put 4 brackets, and finish the case. It's a very nice result. Why? Because we have now a medical treatment, the TMG. Second, the patient doesn't need now a splint. We use a retention in the upper, but do not need a splint. The patient is very happy with the result of the treatment. The treatment was very simple. Was very funny because very cheap for me. We use a removal appliance, 4 wires and tubes, and nothing. And this is a very fast treatment. Is possible to do this treatment with Invisalign? Yes, it's possible. The problem in my office, this treatment with Invisalign is between 3,000 and 4,000 euros. And it's very difficult to combine to a rational patient at the beginning to use aligners or to pay a lot. Okay, I think it's a good result without the risk. Imagine that you put the Invisalign or put in aligners or put brackets and not improve the TMG problem. Okay, I think it's the origin of the problem is a rational origin. It's not emotional origin. Okay. The next. Class 2, division 2nd, TMG. The patient come to the office and say the same. I don't have problems in my teeth. My teeth is more or less correct. My problem is the TMG pain in the ear. The same, I put always the same removal appliance. Okay, to expand 2 screws, protrusion of the incisors. Please check with a 90 euros removal plate. It's possible to do this and more things, because I don't have the photo here, but for the intrusion of the incisor in the next modules and next connections, I show you a lot of cases. I put here a composite, another composite. I put an elastic change here, and to produce the intrusion of the incisor only with a 90 euros removal plate. After the removal plate, you can see the difference only with the removal plate, and now we reduce a lot the time with fixed appliance. It's not two years of removal of fixed appliance. I need fixed appliance in this patient because present a decalage, an inclination of the occlusal plane, and I need to put a mini screw here to for the correction of this desviation. Okay, now we are using thick stainless steel wires, maximum friction. For the reason we are ligate the teeth in a figure of 8 with like a X ligation to increase the friction. And this is a very simple treatment with a very good result, and the most important, with a happy patient without TMG pain, without TMG point, and without inclination of the occlusal plane. Okay, this is the philosophy of the multi-technique. Please combine different appliances in the same patient. It's not more expensive because the appliance that we are using is very cheap appliance, but it's very excellent appliance to problems. This is the mother of a patient, and the mother of the patient said me one day, "Oh, I don't like orthodontic treatment, David. I hate the brackets of my daughter. But my problem is the problem is the TMG. I have a problem with my TMG. I have a pain in the mammaceter muscle. The palpation of the pterygoidal lateral muscle was very painful." Okay, very simple, very simple. The first step, please check the centric relationship. Why the dentists have allergy to take the centric relationship in the patient. It's not only, I recommend a lot the courses of Roth, the courses of the group of FACE. Please, occlusion is very important. To get a very good training in occlusion. Occlusion is very important. This treatment is very, 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 very simple. And I said to the patient, "Oh, I put a Quagel." He said, "No, David, I don't like to put brackets, don't like nothing." Okay. Check. The first step is our nice removal appliance like this. What is the price of this appliance? The price of this appliance is less than 90 euros. It's nothing. And with this nothing, because the price of this screw is 5 euros, with this very nice, I put this, and I am going to cut, for example, here where I cut in the, and with this very nice, easy enough to correct the crossbite. Now it's time to put brackets. Forget the very sophisticated lingual brackets and very expensive. Only one thing for the lingual orthodontic. Only one. Forget the computer. Very simple. Please, bending wires very good. Training, and bending wires. I put brackets from the vestibular, combined with my appliance, put in a splint in the lower with a close bite. Now finishing the treatment with lingual orthodontic. And now it's time to close the bite before the aesthetic treatment of the patient. Very simple. I put an elastic change, put buttons, aesthetic buttons here. You can see here inside the wire and the brackets. Adjust the occlusion, and now we are finishing with the to put composite in the canine guide. And the patient, this is the end of the treatment of the patient, the end before the aesthetic treatment of the patient. Okay, and a very simple treatment and a very happy treatment before the end of the treatment with aesthetic venous. Another patient, this is another patient. What is the treatment? It's possible the patient refuse using 2.5 years of treatment with brackets. And it's possible to use with Invisalign, yes, but I prefer very simple because I prefer to put 14, 12 or 14 aligners or even 15 aligners, but please forget to use 16, 17 aligners because it's crazy. In this case, I put brackets in the lingual, my removal appliance very cheap with my 5-6 euros screw, a nice expansion, a nice intercanine stripping aligner, and now it's time to finish the treatment with aligners, with aesthetic brackets, or whatever. Okay, if you are now put aligners, you need a very short treatment with aligners. If you start with aligners in this way, only for 2 teeth, it's very difficult, the same with this expansion, it's very difficult to use a lot of aligners. Okay, I have a lot of cases. This patient, I need to close this space. The first step is to, with my removal appliance, I put a channel to mesialize the molar, put a couple of buttons in the molar, elastics, and in the upper put 4 brackets, put white buttons in the plastic, to avoid the protrusion of the upper incisors, put brackets, and you can see here. And now it's time to finish the treatment with aligners. Another patient, very class 3, anterior crossbite, oh, this is a very difficult case, but the patient hates orthodontic surgery. The patient refused to use brackets. And what is the patient said me, yes, it's not matter if you put brackets only in the lower arch. I put brackets in the lower arch and in the upper. Very simple. A removal plate with a screw to produce the protrusion of the incisor, a crimpable hook, a hook here for the class 3 elastics, and a lot of stripping in the lower. And you can see a huge overjet for the future rehabilitation after the treatment, a huge overjet, only using a removal simple appliance, very cheap, and brackets in the lower. Okay, now it's time to put a provisional composite in the incisor, and in the future the patient needs the aesthetic solution, but with a new occlusion. Another patient that refused, doctor, I would like Invisalign. Okay, it's possible to put Invisalign, yes, or Invisalign or another aligner. Yes, but I recommend to do this. The first step is a removal appliance to produce protrusion of the incisor. The next is to put composite here and here, elastic change, okay, elastic change to produce the intrusion of the incisor. And with a very simple appliance like this, it's possible to produce protrusion, to correct the deep bite, to produce a little bit the intrusion of the incisor. A lot of things. Now, put brackets in the upper, the vestibular brackets of the lower incisors, class 2 elastics, lingual arch, retention, and finish the case. Only the problem is a little bit, a little bit shift to the mandible to the right, but only this is there. But you can see, in this case, remodeling of the incisal border of the incisor, okay, and you can see the result of the treatment using very simple appliance of our multi-technique concept. Simplify your treatment. Be ecological. Use the patient's own neuromuscular forces. For the reason I am going to ecological orthodontic. For example, this is a typical case, a patient with anterior crossbite. The patient with anterior crossbite needs now the patient. You can see the crossbite in the posterior. What is when a colleague, when an orthodontist see or check or diagnose this case, the colleague is thinking in to put a quachelis or in to put a rapid maxillary expansion. Okay, but you can see I put a very simple composite, a bite block, and with a simple bite block, correct the incisor relationship, and the most important, change the position of the mandible. This is very important in our technique. The name is the propioception. Okay, according with the contact between the upper and the lower teeth, according with the contact during the occlusion, thanks to the trigeminal nerve, the 15th part, is possible to move the mandible forward or backward, forward or backward. In this case, the backward movement of the mandible, produce the correction of the apparent collapse of the maxillary. I put only this, without quachelis, without expansion, without nothing. I put only a piece of resin, the acrylic, and you can see the change of the relationship in the back. Is due to the moving of the mandible in the back. Orthodontic is much more than align your teeth. Understand that orthodontist is halfway between medicine and dentistry. It has a medical vision of orthodontist. I think it's another very important part of our multi-technique philosophy. In the hospital, I see and I saw in the past a lot of the patient with muscular problems. Muscular problems produce skeletal problems. And the skeletal problems is a result of a lot of imbalance between the tongue and the muscles of the lips, the orbicular oris, the buccinator muscle, the tongue, problems with the masseter muscle, temporary muscle, with the canine elevator muscle. For this reason, it is very important for us a new approach to the mandibular class 2 and a new approach to the maxillary collapse. And we are talking about the risk of the sleep apnea,
Risk of the sleep apnea in kids is very, very important. And risk of the sleep apnea in adults is the result of malocclusions in the kids. For the reason when the patient comes to our office, we evaluate the risk of sleep apnea high in patients with a retrognatic mandible. I am going to talk about this in the next modules. Moderate or low. And according with this, we treated and published in 2005 in the Sleep Breath, a very good journal about the sleep, the quality of the sleep, the evaluation of the oral appliance in the treatment of obstructive apnea. Recently, unfortunately, in Spanish, in Castellano, I published the orthodontics in the role of the orthodontics in the sleep pathology. But I remember, please, to check this white paper. The obstructive sleep apnea, according with the white paper of the American Journal of Orthodontic and the International Orthopedic, okay, very important, the relationship between the orthodontist and the sleep apnea. The sleep apnea is spectacular because it's possible with the treatment of the sleep apnea in adults and the treatment of the sleep apnea in kids and the prevention of the sleep apnea in kids is very important to get more and more patients. It's very important to open our office to a new treatment. Okay, it's very important the role of the orthodontist to screen patients, to refer patients, the interrelationship between the otorhinolaryngologist and the maxillofacial surgery. Is recommended to relationship with to evaluate the nasal obstruction or adenoid hypertrophy or otorhinolaryngology. We are working in a very nice research with OrthoPlus, the orthoapnea. Orthoapnea is a new device for the adult patient, but we are going to work in this field because it's very, very nice. Even we have a machine for the patient. I give to the patient this machine from Philips company, and this is a machine for the dental use, okay, to check the risk of the sleep apnea in adult patient and to reach the sleep apnea in kids and to evaluate the effect of the sleep apnea appliance, the appliance to move forward the mandible in the patient. The sleep apnea is very important in our orthodontic philosophy, and in my opinion, continuous oral breathing in association with a maxillary collapse, with retrognatic mandible, not with maxillary collapse in this case, retrognatic mandible, and open bite is the oral breathing in this case is a health problem. Maxillary collapse change the position of the tongue and produce a visual circles. Okay, what is the treatment? I'm going to talk later about this, but the treatment is the rapid maxillary expansion. I like very much a mix. Notice the McNamara, but it's not La Rosa. It's like a mix. It's like La Rosa. The support is the second temporary molar, and you can see here this wire is for the first upper molars to produce the rapid break. Okay, the suture. Very important and very nice when I see X-ray, a frontal X-ray like this with a very nice expansion of the maxillary. Good result, but the most important is this. The change of the face only thanks to the rapid maxillary expansion. A very fast change of the face change, okay, the physiology of the breathing. The physiology of the breathing change the paranasal sinus, change the eyes, change the face, and change the direction of the mandibular growth. Okay, analyze the craniofacial growth, refresh the old functional concepts, open your mind to the new concepts and new technologies. Open your minds, and I am going to show you something new. I create this in collaboration with a Lineadent company, and it's a little bit different to the Invisalign kits. It's not the technology is similar, but change the philosophy of the treatment. Invisalign kits is not, I don't know what is the philosophy of Invisalign kits, but because I don't, it's only with a reservoir for the, and this is the difference. I try to explain briefly because I am going to talk about this later. Because today, for me, for this first contact between you and me, I try to explain all my new concept, not only to talk about the synergy or the wire of the bracket is for up and down. The most important is understand my philosophy of treatment, my complete different philosophy of treatment with a lot of parts, with a lot of techniques, with a mix of the technique to produce in one way. What is the philosophy of our treatment? Very simple. The first step is to get a good occlusion at the level of the molars and a good incisal relationship at the end of the mixed dentition. For this reason, in many cases, we treat first the patient with a conventional utility, with a conventional Quagelis, with a removal appliance, with a functional appliance. The most important part is this. At the end, or in the last phase of the mixed dentition, in the last period of the mixed dentition, we put attachment for retention in the molars, first upper premolars, and normal in the upper and the lower incisor. Okay? Okay? The next step is to get incisal guides, to create the guides, to move the second premolar and upper canine to a class 1. According with the occlusion, according with the trigeminal nerve, the occlusion change the position of the mandible and put the mandible, when the occlusion is in class 1, in an occlusion idea. What is the first? Is the passive proprioception eruption guides. Imagine this. We have to extract the temporary molar, and now we create a box. It's like a box, okay, to maintain the space. This plastic, the polymer is hard, okay, is a little, and mesial and the is okay. After the eruption of this second premolar, okay, we create the guide. This is the guide. We create the guide to move this premolar close and to put this second premolar very close to the first upper molar. The next step at the same time is to create with an attachment the movement of the premolar to distal. Okay, and this is the active proprioception eruption guides. This is a patient with a class 3 malocclusion,
the class 3 malocclusion. The patient present a big decalage between the centric relationship and functional appliance, the protrusion of the lower incisor, the retrusion of the A-point. The first treatment is the use of the Frenkel class 3. I like very much the Frenkel class 3 in this phase of the treatment, because in this phase of the treatment, I need move the point A forward. I need a position of the bone here, and I need to retrusion of the lower incisor, and I need to recollocation of the TMA. For I use the Frenkel appliance. Thanks to the upper pads, the lip pads, eliminate the pressure of the upper lip, and you can see here the eruption of the upper incisor is more and more vestibular, and it's possible to control and to produce more inclination thanks to this wire. Okay, very important, the manufacture. Maybe in the future, we are working now to produce the digital appliance, but not is possible in this type of appliance in this moment. We have a test, but it's not possible. Now we have a twin block with digital design and digital 3D print. Okay, the evolution of the case. You can see the change of the face of the patient, and I think it's incredible that a lot of doctors don't believe in functional appliance. But functional appliance is something spectacular and works very well. You can see the effect of the Frenkel appliance in the area of the anterior part of the maxillary in the upper, and the position of the mandible is something really spectacular. For this reason, I use a lot of the class 3 functional appliance in class 3 patient when is starting the eruption of the upper incisors. Okay, before, in many cases, of the rapid maxillary expansion and the facial mask. Now, we have a very bad occlusion in the back. What is the solution? This. I put you can see here the retention, the first molar, and now we are create the guide to the retrusion of the lower incisor and the occlusion in the back. I think it's very, very, very interesting, the evolution of the cases. Okay, I have now a lot of cases. This is in cases of before the coronavirus, and you can see the result. What is my objective? What is my objective? It's very clear. It's the same objective that Ricketts many years ago with the use of the utility arch. My objective is finish all the treatment immediately after the eruption of the second premolar and the upper canines. For the reason, the eruption proprioception guides change the occlusion. When we control the eruption, control the position of the proprioception, the control of the proprioception, control the position of the mandible and the masseter muscle, pterygoidea muscle, and the different muscle. Okay. Another patient with a TMG problem. The mother was patient maybe 20 years ago at my office, and the mother presented a TMG problem many years ago, very complicated. What is the treatment for this crossbite with huge shift of the mandible?
The first step is very simple. Forget to use in this patient very early an aligner. It's not sense. Not sense. The most simple treatment, Quagelis or a couple of wires to produce expansion. Check now. The TMG is okay. The midline is okay. The mandible is close to two-centric relationship is okay. The expansion of the maxilla is okay. Now it's time to remove the brackets and wires. And now it's time to start the end of the treatment, not to get the eruption of the teeth and after to put brackets, to put the canine or the premolar in the correct position after the eruption. It's not. The idea is very simple. This is the eruption, guys. The eruption, guys. And you can see very nice picture. This is a very nice picture. You can see how the canine is going with the eruption, guys, to the proper position. Okay, to the proper position. Now, you can see here, remove the temporary tooth, and we are using the guys to get a very good occlusion. I have new photos of this case, and I show you a lot of cases in the next modules. One of the great failures of the classical orthodontics is the treatment of mandibular class 2. Class 2 elastics or similar fixed appliances are not the solution. We need a new functional approach. Okay, in many cases, you have a patient like this. The patient presents a huge class 2, a complete class 2, maybe 10%, 20% of this patient is a maxillary problem, protrusion of the upper incisor, but 80% of the problem is a retrusion of the mandible. Retrusion of the mandible. The retrusion of the mandible, and this is a huge problem. This is a huge problem. Okay, dolichocephalo patient, protrusion of the upper incisor, retrusion of the mandible. Okay, width class 2. Occlusal, according with the occlusal functional plane, retrusion of the mandible, according with the vertical pterygoidea, present a rotation and mesialization of the molar. Okay, the distance, we are going to talk in the next modules about this. Okay, no problem. The distance between the upper first molar and the vertical pterygoidea muscle is increased. I think it's very important, this measurement, to take a decision about the distalization of the molar. Hypothesis. Okay, what is the treatment according with tooth? According with Roth, according in many cases, or extraction, or in the future, orthodontic surgery of the mandible. Okay, okay, and I think it's very important to understand that most of the cases with adequate orthopedic treatment produce a very good result that eliminate or diminishing the need of extraction or the orthodontic surgery, or simplified the orthodontic surgery in the future. Okay, what is the mistake in this case? The mistake in this case, in 90% of the clinics, the mistake of this case is to use distalization of the molar with headgear, with pendulum, with carriere, to distalize the molar in combination with class 2 elastic. This is a complete disaster. Please, it's very important to understand the mandibular class 2, because in Russia, in Ukraine, in Spain, in Italy, in France, most of the patients with class 2 present a very severe mandibular class 2. And according with a lot of techniques nowadays, it's not possible to treat the mandibular retrusion and using only class 2 elastic. And the class 2 elastic, okay, is horrible for this type of patients. What is the concept, the classical concept, and the evidence-based concept? I'm going to talk very briefly and finish with this case. Imagine this. The train, the machine, the train is the mandible. And the cars on the train, or in the train, the cars are the teeth. Okay? If I need to move the mandible, I move the train. Okay, I move the train. When I move the train, move the teeth. Another possibility, different, is this. It's not possible to move the mandible. It's not possible to move the train because the patient is an old patient, and I need an adult patient, and I need to move only the teeth to produce the protrusion of these teeth. I move only the cars. Okay, I move only the cars. In my patient, in our patient, I need to move. I need to move the train. Forget to move the cars, please. We need to move the cars later, but at the beginning, we need jumping the bite. Okay, please, it's very, very important. It's completely different. What is the best appliance to move the cars? The best appliance to move the cars is the class 2 elastics or appliance like class 2 elastics. For example, the Fortus, this is an excellent appliance for 3M company, the Liberty VL by Rocky Mountain. All this type of appliance is class 2 elastic effect, and it's very good to move the cars, but it's a completely disaster to move the train. In this patient, what is the treatment of multi-technique? Very simple. The first step is to align the teeth. In many cases, we need to increase even the overjet, because you need overjet to move forward the mandible. If you don't believe in to move forward the mandible, it's impossible to treat this patient. We are talking in this case about the Roth philosophy. Next step is to distalize the molar. We need to distalize the molar. Distalize the molar. What is the best appliance to distalize the molars? Depends. I am going to talk about this later, no problem, okay? I am going to talk about our protocol. For example, Quagelis is very good for expansion, good for the rotation, is not good for distalization. Cervical headgear, patient refused the cervical headgear, but is very good for anchorage, is very good for distalization, is not good for disrotation. Pendulum appliance, very good for anchorage, more or less for expansion, very good for disrotation, and very good for distalization. Microimplants, very good for anchorage, very good for disrotation, and very good for implants. The first step in this patient, jumping the bite. Jumping the bite, I don't discover the jumping the bite. Angle, talking about jumping the bite more than 1 century ago. Jumping the bite is to put the mandible in a new spatial position. And for the jumping the bite, the best appliance is a functional appliance, using during the night only, okay, and at home, about 16 hours a day. After the use of jumping the bite, okay, you combine the jumping the bite, I don't have here the photo, with a utility. Why? Because the parents want to see very early during the treatment the upper incisors in a correct position. Next step is this. Next step now, when we have a fake class 1, the condyle is not in the centric relationship when the patient is in class 1, but this is a confused. We have now a new functional position in class 1, and now we eliminate or remove, the functional appliance. And now it's very important for you to understand what is the classical concept and our concept. What is the classical concept? It's very simple. And the classical concept is you put a functional appliance, a twin block or another type of appliance, and the main objective of this functional appliance is to stimulate the growth of the condyle. This is for the experiments many years ago from McNamara in monkeys. Okay, this is the classical idea. After they stimulate the growth of the condyle, the growth of the TMG, the growth of the ramus of the mandible, now it's time to put brackets and to engage the occlusion in class 1. Okay. This is the classical evidence treatment. Please forget cornucopia. TMG is not the cornucopia. We are not specialized in TMG. We are specialized in dentoalveolar bone. In alveolar bone, we are the best in the world in the alveolar bone growth. And the orthodontic surgeries are very, very, very brave and very good in basal bone, but they are not very good in dentoalveolar bone, because dentoalveolar bone is our bone. It's different. The first step is jumping the bite. The next step after jumping the bite is to get a new stable position of the condyle. Now put brackets in class 1, and now we create a new functional device. What is the new functional device? Is our occlusion, the new occlusion in class 1 of the patient. And we have a lot of time for the growth of the condyle of the patient. This is very, very important. For this reason, the main objective of the functional appliance, forget the growth of the condyle, forget the growth of the cartilaginous, forget the growth of the mandible. The main objective of the functional appliance in our philosophy is jumping the bite, to put the mandible in a new position, and the brackets in class 2 elastic. We use the bracket in elastic for this to engage in a new occlusion and create a new appliance. Okay, and we have not 1, 2, 3, 10. We have a lot of cases. And we get a stable condylar position in most of the patient. Okay, This is the evolution of the occlusion, the elastic, the class 2. Okay, this is the biomechanics to finishing. Okay, we're using gunmetal or beta 2 titanium, elastic, step for the adjust the occlusion, and at the end we have a very stable occlusion. This is the patient years after the treatment, the patient more years after the treatment, and the patient 7 years after the treatment. Okay, because I am going to show in all of these cases the follow-up of the patient almost 5 years out of retention. You can see the patient nowadays, more or less about 7 years after the treatment or 8 years after the treatment, with a very nice functional occlusion, with a nice occlusal disocclusion. And you can see here what? You can see here the treatment. You can see here the evolution of the case. The first step is the dento-alveolar effect. Thanks to the use of distalization forces, brackets, wires. TMG and ramus basal bone effect, thanks to the occlusion, not thanks only the functional appliance. And dento-alveolar effect and basal bone effect is a mixed effect between the basal bone effect and the dento-alveolar effect at the level of the mandible. Okay, next day, I am going to talk about the cephalometric analysis, our cephalometric analysis, because I don't have a lot of time. I am going to talk about the objective in orthodontic, our objective in orthodontic, and our protocols. Excuse me, because the first idea was to talk about the objective in orthodontic, occlusion, but I think I changed a little bit the program, because my idea is to show you the complete different techniques of the multi-technique, and how to join, how to combine all the different and classical orthodontic appliances and new orthodontic appliances to get the best results in a very difficult moment for the humanity. In the next 2, 3, or 4 years, we are going to very severe problems in orthodontic for the patient accept very expensive appliances. We are going about the Invisalign, very long treatment with Invisalign. We are going to use very sophisticated lingual appliances. Okay, I think it will be a little bit complicated. For the reason multi-technique, the idea is to simplify the treatment. To get this treatment is about in my office in Spain. I suppose that in Russia or Latin America is different in 8 countries, but it's not a very expensive treatment for me, okay? And I think it's very, very interesting, because I am going to diminishing the time of the treatment, diminishing the fees of the treatment, and using very simple appliances, okay? Okay, thank you very much. And now is questions, okay? Questions about the lecture. If you have questions, I think is the time to respond to these questions. Okay. Do you have questions? It's possible to send me to my WhatsApp, and I try to. Okay. If you have questions, 1 minute. Okay.
maybe in the future, after the pandemic, it's possible to organize after this course something here in my country, in Spain. I hope, because after this complete disaster. Okay, if you have questions, please send to the translator. Next time I'm going to talk about this, about the diagnosis, the plan of treatment, the BTO, how to use the PowerPoint, very simple PowerPoint to analyze the cephalometric analysis, the 2-dimension and 3-dimension treatment, and I am going to explain step by step. I am going to explain appliance by appliance, okay, how to combine all these questions. If you like, in the next module, it's possible to show cases, okay. No questions, okay.